تفضل دكتور أسامة.
شكرا دكتورة فاطمة. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. I'm Dr. Osama Twajri, consultant of Obstetric and Fetal Medicine from Obstetric Department BSMMC Riyadh. I would like to welcome you all in my presentation for today, Obstetric Emergencies. Obstetric emergencies are any health problem that life-threatening for pregnant women and their fetus or baby. The obstetric emergency may arise at any stage or time during pregnancy, labor, and birth. And the hospital care is needed for all obstetric emergencies, as the woman may need special care and sometimes need to have extended hospital stay. The management usually the responsibility of hospital obstetrician. And always we are insisting that the principle of dealing with obstetric emergency are the same as for any emergency, which include airway, breathing, and circulation. But we need to remember always that in obstetric, there is a fetus which is very sensitive for maternal hypoxia. Regarding the maternal death, there is direct or indirect causes. For the direct causes of maternal death, which are the result of a complication of pregnant state, which could happen at any stage of pregnancy or labor, or sometimes during period, or from the intervention or incorrect treatment, or from the chain of events arising from any of them. On the other hand, the indirect causes of maternal death, those are due to the previously existing disease or the diseases that develop usually during pregnancy. There is a very long list of obstetric emergency events, which we can mention it, but I select the most common and serious events which need highly concern and need more action. And this list includes cord prolapse, shoulder dystocia, uterine rupture, uterine inversion, postpartum hemorrhage and coagulation disorders. And lastly, we are going to cross through the sudden maternal collapse. So we will start with cord prolapse. What's cord prolapse? The cord prolapse when the cord slips ahead of the presenting part of the fetus and protrude into the cervical canal, vagina, or sometimes beyond that outside the maternal body. We need to differentiate between the cord presentation and cord prolapse. And in this situation, the cord presentation need intact membrane. So the fetal umbilical cord ahead of the fetal head, but still there is still intact amniotic fluid membrane. So there is no leakage of fluid. But in case of rupture membrane, the cord will slip ahead of the fetal head, which may at the level of cervical canal or vagina, or sometimes protrude outside the maternal body. There is many factors, maternal or fetal, leading to not well engaged or fetal presenting part, which lead to a slip of the cord during rupture membrane. Those factors include malpresentation, especially during conducting delivery of breech presentation, or malpresentation like in case of transverse, oblique, or unstable lie. Actually, one of the most common cause of cord prolapse is prematurity, because it's associated usually with low birth weight. Another factor usually we are facing during conducting delivery for the second twin, or in case of occupying the lower uterine segment or by any object like low-lying placenta or uterine malformation or fibroid, or even sometimes with pelvic deformities. Some obstetric maneuvers, like in case of external Podalic version or internal podalic version or external cephalic version may lead to cord prolapse if the membrane ruptured. Multiparity and polyhydramnios also from those factors leading for cord prolapse because of extended uterine cavity, which as a factor which preventing part from wool engagement. Also, cervical ribbing in case of inducing labor by using balloon catheter, because this balloon will preventing the fetal presenting part from occupying the cervical canal and preventing the cord from slip. Induction of labor by any mean, because we are forcing the uterus for contraction sometimes prematurely before will engage the fetal presenting part. Application of fetal scalp electrode. This technique usually painful for the fetus, because once we insert the fetal scalp over the fetal head, he will feel pain, so he will move and pull his head up, so the cord will slip. As I mentioned previously, external cephalic version or internal podalic version, also those are a maneuver which rotating the fetus from position to another, so it will lead sometimes for cord prolapse. Applying of instrumental vacuum or forceps prematurely may lead to have some complication, especially with cord prolapse, because if you apply it before very well engagement or presenting part at the level of allowing for applying the instruments, it will end by multiple complications, one of them cord prolapse. How we can expect cord prolapse? When the fetal heart rate on the CTG monitor starts showing some changes immediately after rupture membrane, especially persistent fetal bradycardia, prolonged fetal bradycardia, or moderate to severe variable deceleration, we need to expect cord prolapse. So it's indicated for immediately vaginal assessment to rule out cord prolapse. The definite diagnosis of cord prolapse by clinical assessment, usually by examining the patient vaginally, and we will notice there is a cord prolapse through the vaginal canal, pulsating, or sometimes if stay long time with very well compressed over the cord, there is no pulse. But once we feel the cord protrude ahead of the presenting part with rupture membrane, that means there is a cord prolapse. How we can put a very long list of differential diagnosis based on any events giving the same picture of cord prolapse. As we mentioned before, the first sign after rupture membrane or while the membrane rupture is any change in the CTG. So if there is uterine hypercontraction or change in the maternal blood pressure, placental abruption, or uterine rupture, or even vasa previa, it will affect the CTG monitor. We will notice some fetal deceleration. At the same time, there is bradycardia or persistent variable deceleration. So it gives us the same differential diagnosis for cord prolapse. How we manage those cases with cord prolapse? Usually, we need to assess the fetus status immediately. If the fetus is still alive at the time of cord prolapse, or if it's dead. If the fetus dead and the clinical situation of the patient is stable, she is not bleeding, and she can wait for conducting vaginal delivery, the method of delivery is vaginally, because there is no aim of getting this baby immediately by doing cesarean section. But if the baby is still alive, we need to assess the cervix and possibility of conducting vaginal delivery. If we assess the cervix and we found the cervix partially dilated, it's not fully dilated and not imminent for conduct immediate delivery, cesarean section indicated that time. But if the cervix is fully dilated, we need need to put in our consideration. If we can conduct the delivery immediately by encouraging her to push or by applying the forceps and get the baby immediately, it's fine. Otherwise, if any presentation other than Catholic or high presenting part or any situation will delay getting the baby out immediately, cesarean section indicated that time, because any delay, it will lead for more compression over the fetal umbilical cord and reduce the fetal circulation, which leading for asphyxiated baby and complication. This is regarding cord collapse. Any question? Now we are going to talk about shoulder dystocia. Shoulder dystocia, now it's one of the critical situation which we don't like to face it during labor, because it's lead a lot of effort and a lot of people handling with the patient to conduct the delivery. What's shoulder dystocia? Shoulder dystocia, that means we are facing a difficulty in delivery of the shoulder after delivery of the fetal head, because of the anterior fetal shoulder impacted behind the symphysis pubis. So the fetal rest of the body will stuck and we cannot get the baby out. The incidence of shoulder dystocia, 1 in 300 vaginal delivery, which is considered as significant number. There is very long list of risk factors leading for shoulder dystocia. Unpredictable cause of shoulder dystocia is the most common. After that, we can predict shoulder dystocia in case of macrosomic baby, especially with maternal obesity, because of maternal diabetes and postpartum gestational age or pregnancy. Malrotation of the shoulder, also leading factor for shoulder dystocia. Any pelvic deformity or tumor of the fetal thoracic abdomen or fetal ascites, sometimes preventing the fetal body from descend and deliver smoothly. Applying forceps or ventouse associated with the high incidence of shoulder dystocia. A previous history of shoulder dystocia indicated to be alert everybody in labor ward from repetitive the scenario again. How we manage shoulder dystocia? Uh, Conducting delivery for a patient who is facing shoulder dystocia needs multidisciplinary team at the same time. We need staff nurse, we need anesthetist, we need theater to be standby, we need assistants, we need expert physician to be around and conducting the maneuvers. The first and the most common effective maneuver called macrobot technique. This technique, by putting the patient with exaggerated lithotomy position and sharply flexing the leg upon the maternal abdomen, and by doing this, the symphysis pubis is rotated and the sacrum is straightened, and a high percentage of the cases will be delivered smoothly by this maneuver. Actually, we need to drop the patient, we need to empty the bladder, and we need sometimes to do episiotomy to facilitate more window for manipulation and extraction of the fetal body. If you fail to get the baby by doing macrobot maneuver, we can do suprapubic pressure, gentle pressure with rotating the anterior shoulder toward the fetal chest. It will facilitate the fetus to be delivered or the baby to be delivered smoothly. We need to insist again, the bladder should be empty, and generous sometimes episiotomy should be done. If we failed, we can do wood screw method. This the wood screw method. We will do some way around. We are going to rotate the posterior shoulder. We need to rotate the posterior shoulder toward the fetal chest. This maneuver, once we rotate the fetal shoulder toward the fetal chest, this side, the anterior shoulder will be released from the symphysis pubis, so we can release the anterior shoulder and get the baby out. During the maneuver, or sometimes intentionally we can do fracture or cut off the anterior clavicle, which is risky also for nerve injury, but sometimes it's indicated in case of prolonged procedure, and we need to get the baby as soon as possible, because this procedure will reduce the bicornuate diameter, which facilitate getting the baby out smoothly. Symphysiotomy, it's done rarely, and it's very complicated procedure, which is not recommended usually because of visceral injury and maternal trauma, which is not recommended usually. The Vinelli maneuver, this maneuver is the last option usually we can offer for the patient in case if we stuck to get the baby vaginally. We will grasp and push the fetal head inside the vagina toward the uterus and do immediate cesarean section and get the baby out. Unfortunately, once we notice there is a shoulder dystocia, complication for maternal and fetal is highly alert and should be considered and put in our mind. First of all, fetal complication, asphyxia, and sometimes fetal death or neonatal death, it's highly reach up to 20 to 30%. Injury of brachial plexus nerve or even Erb's palsy, as well as facial nerve injury, fracture of a clavicle, humerus, and rarely cervical spine can be noticed. For the mother's complication or maternal complication, the mother can face cervical, vaginal, or even perineal laceration. Extension or extended episiotomy can be noted, sometimes limited to the vagina, and unfortunately sometimes extend to the level of the cervix, or sometimes extended more than this to reach to the cervix, to the uterus, sorry. Postpartum hemorrhage due to laceration and uterine atony is obviously seen with those cases, and rupture of the uterus because of aggressive and manipulation of the hand inside the uterine cavity to manipulate the impacted shoulder. This regarding shoulder dystocia. Any question? The third obstetric emergency we are going to talk about is uterine rupture. The incidence of uterine rupture range between 1 in 1,000 to 1 in 3,000 deliveries, and 95% of the cases occur with multiparous. The uterine rupture, either complete or incomplete uterine rupture, we can differentiate between both of them with, in case of there is a peritoneum covering the uterus. So if the uterine rupture happened and still the visceral peritoneum is still intact, we call it incomplete uterine rupture. But if the visceral peritoneum ruptured and there is a leakage of amniotic fluid, or sometimes placental or partial or complete fetus to the abdominal cavity, we call it complete uterine rupture. If there is bleeding associated with rupture, it's depend of type of rupture and the sequence of rupture. It's variable. If the uterine artery or one of its branches torn, severe bleeding will be occurred. But if the uterine rupture is small in size, fibrotic edge, sometimes it's not bleeding, and in bad situation when the placenta completely delivered and the complete fetal pushed out of the uterine cavity through the uterine rupture incision, and the uterus become well contracted, the bleeding may be slightly after the event actually of bleeding, episode of bleeding. When the rupture occurred, the rupture could occur during the pregnancy or during the labor. So the ruptures which happened during pregnancy, we can divide it into spontaneous rupture or traumatic rupture. The spontaneous rupture during pregnancy, any rupture of the scar to the scar of the uterus due to previous cesarean section, myomectomy, or previous uterine perforation during DNC or any uterine procedure. Because usually with extended of the uterus during pregnancy, and the incision of the myomectomy or previous scar is weak, not strong enough to occupy or hold the pregnancy, spontaneously will rupture during pregnancy before the patient goes in labor. The traumatic rupture during pregnancy due to any direct trauma to the abdomen, like in case of RTA, or fall down toward or direct to the abdomen, which lead to rupture uterus during pregnancy, or using excessive force over the uterus, especially during external cephalic version. This maneuver, we are doing it in case of breech presentation. We are using this maneuver to change the fetal position from breech presentation to cephalic presentation to facilitate vaginal delivery. Or the rupture, uterine rupture, happened during labor. Again, it's either spontaneous rupture during labor or traumatic. Spontaneous rupture, in case of a previous cesarean section scar, it will rupture spontaneously, or in case of abruptio placenta, because increased intrauterine pressure, or irritation because of intrauterine bleeding. Multiparity associated usually with exhausted uterus and thin uterine wall, which more prone for uterine rupture. Obstructed labor for any cause, either one of the causes contracted pelvis or inadequate uterine contraction or irregularity in uterine contraction, which lead for prolonged time of labor. This prolongation of uterine contraction during labor for many hours, it will make the uterus more exhausted, risky for rupture anytime. Actually, maluse of oxytocin drip may lead to uterine rupture. A previous cervical tear, which may extend upward with the onset of uterine contraction, also one of the causes of spontaneous rupture. What about traumatic rupture? Using any instrumental delivery, like in case of forceps, or doing breech extraction before fully dilated cervix, it will lead for uterine rupture. Internal pedalic version for the second twin, because of multiple internal manipulation by obstetrician hand, may lead to, less likely, but may lead for uterine rupture. Manual removal of the placenta, if the placenta stuck after delivery of the baby from spontaneous separation and delivery of the placenta, we need to take the patient for manual removal of the placenta under general anesthesia. By doing this maneuver to separate the placenta, may lead for uterine rupture. There is fetal and maternal complication we can face if in case of uterine rupture. The maternal complication, the maternal mortality reach up to 10% of the cases of uterine rupture, most of them because of shock, hemorrhagic shock, infection, paralytic illness, and sometimes amniotic fluid embolism and injury to the viscera around, like the bladder, uterus, or other abdominal organ. The fetal complication, the mortality rates for the fetus is high, reach up to 75% due to placental separation and leading for fetal asphyxia. What are the prophylactic measures and treatment for uterine rupture? We need to put some consideration in our mind during pregnancy for those patients who is risky for uterine rupture. We need to do antenatal care to detect any fetal or maternal abnormality which may lead to obstructed labor. The patient whose grand multipara should be delivered in a hospital, and patient with upper segment cesarean section scar must be delivered by elective cesarean section at 38 weeks. And the treatment measure and prophylactic during labor, we need to consider proper use of oxytocin drop, and there is no place or very caution use of forceps or breech extraction before fully dilatation, which prohibited completely. Exploration of the uterine cavity indicated after delivery in the presence of uterine scar, after instrumental delivery, or after difficulty of delivery. If we face a case of uterine rupture, what active management we can do? The patient need to provide with anti-shock if she exposed to shock, whatever type of shock. Uh, Immediately laparotomy after stabilization of the patient. The fetus should be delivered and the placenta should be removed completely. Hysterectomy sometimes indicated if in case of uncontrolled uterine bleeding. And if there is a rupture scar, cesarean section should be done within 2 weeks, 2 weeks before the expected date in next pregnancy. So if the patient face uterine rupture at age of 38 weeks, the next pregnancy we need to deliver this patient at 36 weeks, 2 weeks before the expected day of time of uterine rupture previously. This is for uterine rupture. Any question? The fourth obstetric emergency we are going to talk about uterine inversion. What's the meaning of uterine inversion? Uterine inversion is when the inner uterine cervix turn outside. That means the inner side become outside. Endometrium become exposed outside the uterine cavity. The incidence of uterine inversion ranging between 1 in 2,000 up to 1 in 20,000 deliveries, and the mortality rate reach up to 30% because of shock, because of hemorrhage, because of infection, and sometimes because of pulmonary embolism. We have something called acute uterine inversion, which occurred during or immediately after delivery of the fetus, and so it's called acute purpular inversion. What's the etiology of uterine inversion? The uterine inversion could be spontaneous or induced inversion. Spontaneous inversion due to precipitated labor, short fetal umbilical cord, maternal straining or severe cough immediately after labor while the uterus is still lax and not well contracted. The induced inversion usually happen due to a pressure on the fundus or traction of the umbilical cord while the uterus is still not well contracted. Also, if we are facing a case of placenta accretia, which means that the placenta adherent to the uterine wall, and we are pulling the umbilical cord, it will lead for uterine inversion. Actually, we need to differentiate between uterine inversion and core and uterine prolapse. Uterine prolapse, that means whole the uterus will be protruded through the vagina, or sometimes outside the introitus. But uterine inversion, the inside layer of the uterus will be inverted outside, and it's grades. First degree uterine inversion, the fundus of the uterus will be deep, making a cupping of the fundus, which and this inverted of the fundus is still above the level of the cervix. That means if we examine the patient vaginally, we'll see the cervix and we cannot see higher than this. But if we are doing ultrasound scan through the abdomen, we can diagnose it easy. There is a cupping of the uterine fundus. So first degree usually above the level of the uterine cervix. Second degree when the inverted uterus protrude through the cervix into the vagina. So if we examine the patient vaginally, we can see the endometrial layer of the uterus throughout the cervical canal. The third degree when the uterine fundal appear or protrude through the vagina, and we can see it obviously outside the maternal body. The first and second degree are called incomplete inversion, while the third degree called complete uterine inversion. What are the clinical pictures? The patient usually complaining of sudden severe lower abdominal pain, sometimes associated with bleeding. Due to uterine atony, usually the bleeding become obviously seen, but if the uterine inversion become complete, usually the blood supply to the uterus kinked, so the bleeding is not that much obviously seen through the vagina. So the bleeding not that much with third degree uterine inversion. But the first and second degree, you can see obvious and significant amount of vaginal bleeding. Rarely the symptoms are mild or absent and the conditions passed unnoticed until the patient develop fever or blood stain offensive vaginal discharge due to infection. So we call it subacute type of infection. So in the first or second degree, easy to be missed if the acute symptoms mild. So sometimes we discharge the patient home and come a few days later complaining of lower abdominal pain, fever, and offensive discharge. What are the signs of uterine inversion? When we examine the patient vaginally, examine the patient generally, first of all, we can face variant degree of shock, hemorrhagic shock or neurologic shock. The hemorrhagic shock due to blood loss. If the patient facing first or degree uterine inversion, she will bleed significant amount of blood. If this amount of blood missed to be managed or replaced, she will face hemorrhagic shock. At the same time, the vasovagal reflex for the patient because of traction of infundibulopelvic ligament, it will lead for neurologic shock. In the first and second degree cupping of the uterine fundus, if we examine the patient abdominally, you can feel the uterus abdominally. But in case of third degree uterine inversion, if you examine the patient abdominally, you will not palpate any part of the uterus because it's already protruded through the vagina or sometimes outside the maternal body. So ultrasound scan can diagnose easy. If you put it over the patient abdomen, there is no uterus in the abdomen or pelvis. If you examine the patient vaginally, the second and third degree uterine inversion, you will notice a large mass in the vagina covered with dark red endometrium, and the placenta sometimes attached to the inverted uterus. How we treat those patients with uterine inversion? The patient initially need to be stabilized. So if the patient in shock, we need to correct her situation and improve her shock status. And after that, we need to do manual reduction of the uterine inversion by pushing the patient to the theater and put her under general anesthesia and ask the patient to give the anesthetist to give the patient halothane or nitroglycerin to make the uterus relax, and we can do some maneuver to retain the uterus to normal position. After reduction of the uterus and removing of the placenta, we can do gentle massage to the uterus and start here with ergometrine, or give the patient intravenous oxytocin drop, which improve the uterine contraction. The patient actually need to be covered with the broad spectrum antibiotic to reduce risk of infection. One of the maneuver we can use to retain the uterus to normal position, the obstetrician can introduce his left hand gently with using some lubricant through the vagina and retain the uterus gently to normal position. This maneuver should be done in the theater uh, because we need to ask the anesthetist to give the patient hallucine to make the uterus more relaxed. And this maneuver risky for exposing the patient for anaphylactic shock. So we need to do it in a proper place. All the measures of precaution should be taken. Anesthetist should be around. The patient should be under general anesthesia. The patient should be vitally stable, blood available. Expert person who can do it should be around, and if it's possible, he need to do it himself. If she is bleeding, we need to control the source of bleeding, and after retaining the uterus to normal position, we need to start her an oxytocin drip and ergometrine, and sometimes we can give her misoprostol rectally or sublingual to make the uterus well contracted. After ensure that the uterus become very well contracted, we can remove our hand from the uterus gently and do ultrasound scan to make sure still the uterus in place. And after that, we can keep her for observation for a while. Then we can shift her to the HDU. If we face difficulty to introduce our hand through the vagina and the cervix, we can do something called hydrostatic method. This hydrostatic method used by inflates the vagina and the uterine cavity with around 3 liters of sterile saline, which increase the uterine cavity pressure gradually. This pressure will reduce, replace the uterus to the normal position again. This technique and the measures and the precautions will be taken as if we are doing it manually. Sometimes we can use the balloon with capacity of 3 liters. The same technique, we can put it in the vagina or the lower part of the upper part, sorry, of the vagina, and inflate it with the sterile saline gently and slowly until we achieve the return of the uterus to normal position. If we fail of those maneuvers, we can use a surgical technique. We need to open the patient abdomen and do it surgical correction of the feet of the uterine position. Any question? Now we are going to talk about postpartum hemorrhage and coagulation disorders. The postpartum hemorrhage may be a primary or secondary. The primary postpartum hemorrhage is excessive bleeding from the genital tract more than 500 mL, which occurred during the first 24 hours after delivery of the fetus. And the primary postpartum hemorrhage incidence reach up to 5% of vaginal deliveries, and there is usually underestimation of the blood loss during labor, reach up to 50%, and this because of we missed to count the soaked blood in the garments, drapes, and the linen, or sometimes even the blood in the floor. It's not measured. Because of that, we need to put or consider in our mind usually the estimated blood loss less than the real amounts of loss by 50%. The secondary postpartum hemorrhage is the bleeding from the genital tract, which occur after 24 hours of delivery of the fetus and up to the end of puerperium period. The source of bleeding, usually the hemorrhage from the placental side or from extraplacental side due to laceration of the genital tract. The placental side hemorrhage, either due to uterine atony or due to retention of partial or complete placental tissue, which interfere with retraction of the uterus and become very well contracted. Sometimes we are facing coagulation disorder due to disseminated intravascular coagulation, thrombocytopenia, leukemia, or even von Willebrand disease or any other hematological disease which interfere with coagulation of the patient and lead for postpartum hemorrhage. If we are facing uterine atony, which is the most common cause of primary postpartum hemorrhage, 90% of the cases. And those uterine atony causes because of anemia. Why anemia lead for postpartum hemorrhage? The patient who is anemic, she will face less blood oxygenation supply to the uterus. Because of that, we cannot get significant or sufficient amount of oxygenation blood, which indicated for good uterine contraction. If the patient face antepartum hemorrhage, again at the time of delivery of or postpartum, she will have less hemoglobin level, which again she will be anemic and no more strength in the uterine contraction. Multiparity and prolonged labor, those factors, because of exhaustion of the uterus, very easy for them. Excessive sedation and deep anesthesia, there is correlation with general anesthesia and postpartum hemorrhage because it affects well-contracted uterus. There is local cause for primary hemorrhage, like in case of multiple pregnancy, macrosomia, polyhydramnios. All of those, the uterine size is huge in size, which need time and efforts to get very well contracted uterus. Uterine fibroid, again, it will interfere with achievements of well uterine contraction, presence of uterine scar. Also, the uterine scar will prevent or make the squeezement of uterine vessels not that much easy, retain of placental fragments or blood clot or piece of membrane. It will interfere also with uterine contraction. So if you found any placental piece or blood clots, we need to remove it from the uterine cavity to achieve very well uterine contraction. A traumatic postpartum hemorrhage, it's due to laceration of the perineum, vulva, vagina, cervix, or even sometimes with rupture of the uterus. Acute incomplete uterine inversion may lead to postpartum hemorrhage. How we manage the antepartum postpartum bleeding? We need to do antenatally proper management and care for the patient and keep her hemoglobin level above of 100 gram per deciliter throughout her pregnancy. And any woman who's predisposed previously to postpartum hemorrhage, as in case of multiple pregnancy, grand multiparous, or previous history of postpartum hemorrhage, should be delivered in a hospital who can deal with those patients with facilitate of good blood bank who can provide the delivery units with good amounts of bucket RBC to correct her bleeding. They should have the patient should have blood group and save cross-match blood during labor to transfuse here immediately at the time of indicated. During labor, we need to do proper use of analgesia, anesthesia, plus routine use of active management in the third stage of labor is indicated. And there is no place to use forceps or breech extraction before fully dilated cervix because the risk of visceral injury is very high, especially to the cervix, and we will stuck and affect even the fetus. For the patient with the placenta and membrane which retain, we need to remove it and exclude it by doing a bedside ultrasound scan. The uterus and birth canal should be explored after any obstetric operation and using forceps to detect any tear. Every patient should be observed for at least 1 hour after delivery to detect any postpartum hemorrhage situation. For the traumatic postpartum hemorrhage, under general anesthesia, we need to explore the birth canal and we need to examine the uterus. And sometimes a tight vaginal bag we need to apply to control the oozing from the cervix and vagina because after delivery, the cervix and vagina is very fragile and suturing of the vagina not that much easy to achieve hemostasis. So we can apply uh, some packs, vaginal pack, which work as tamponade to stop the bleeding from the vagina and from the cervix. Actually, the bleeding because of ruptured uterus should be treated either by correction, by suturing, and if we face difficulty to achieve hemostasis and control the bleeding after all the measures, we can do hysterectomy for the patient to preserve her blood and save her life. Bleeding due to uterine atony, uh, the bladder should be evacuated and uterine massage should be done to accelerate uterine contraction. And we can give her ergometrine 0.5 milligram, either IV or IM, or we can give her intravenous drip of oxytocin. If all those measures fail, we can use prostaglandin, which can be given either IM, IV, or through the drip. Misoprostol can be used vaginally or sublingual, which work effectively, and our experience is very good with the misoprostol. If the bleeding not controlled, the patient should be taken for examination under anesthesia, and the uterine cavity should be explored manually and remove any retained placental tissue from the uterine cavity. We can do a bimanual compression for the uterus. This technique, we can use it to reduce the bleeding till we can get the medication agent, till we can achieve any further blood from the blood bank, till we have the expert person how we can deal with the patient, even in the theater till the anesthetist put the patient under general anesthesia. This bimanual compression is very nice and need the one who can do it easily with some experience. He can insert the left hand transvaginally to the anterior fornix, and by the other hand, he can compress the uterus from the posterior uterine wall transabdominally, and bimanual compression will preserve a lot of bleeding. We can do it till we are stable to do the next step of management. We can do ligation for the vessels, ligation of ascending branch of the uterine artery, ligation of internal iliac artery, or the anterior division. This can be done surgically, or sometimes if the patient is stable enough to be shift to radiology department, we can do it by interventional radiologist, do embolization for those vessels. There is a place for B-Lynch suture, which can be done if we face bleeding from the uterus and we fail to achieve medical management. We can do this B-Lynch stitch technique. It's very easy, applied, working as a tamponade for the uterus to achieve reduce amount of blood loss from the uterus. What complication we can face with postpartum hemorrhage? The maternal death reach up to 10%, acute renal failure, Sheehan syndrome, failure of lactation, anemia, increased incidence of puerperal sepsis. The secondary postpartum hemorrhage, the incidence reach up to 0.5 of deliveries. The etiology of postpartum hemorrhage, either because of retained placental tissue or piece of membrane, 50% of the cases, uterine infection, submucosal fibroid or polyp, inversion of the uterus, sometimes malignant trophoblastic disease, invasive mole or choriocarcinoma, and the placental side trophoblastic tumor, or local gynecological lesion like in case of cervical erosions or carcinoma, hemorrhagic blood disease as in case of thrombocytopenia. The treatment, we should treat the cause. If there is retained placental tissue, which diagnosed by using ultrasound scan or hysteroscope, in this situation, we need to evacuate the uterus and start here on ergometrine and give the patient antibiotic. If the bleeding persists or severe, the uterus need to be cured and do examination and send the product for histology to exclude malignant trophoblastic disease. Any question? Sudden maternal collapse. There is two causes, either obstetric cause for sudden maternal collapse, which include postpartum hemorrhage, ruptured uterus, excessive laceration of the cervix, vagina, or perineum, inversion of the uterus, amniotic fluid embolism, eclampsia, or a complication of an ovarian cyst, torsion, or rupture. Non-obstetric causes, coronary thrombosis, pulmonary thromboembolism, anesthetic accident, epidural anesthesia may be complicated by hypotension and cardiac arrest. Any question? Actually, I have a very long list of references. I summarized for those, and this is my presentation for today, and thank you.
يعطيك العافية دكتور أسامة التويجري، كانت محاضرة رائعة. Any question؟ شكرا للحضور جميعا، الله يبارك لكم جميعا. شكرا.
شكرا لكم، شكرا دكتورة فاطمة.